Welcome everyone. Thank you for joining us. Our webinar today is entitled Small Intestinal Bacteria Overgrowth, Updates and Clinical Implications. Our speaker is Dr. Christine Stubbe. My name is Lenore Powell. I am a medical education specialist in Genova's Atlanta branch. I'm going to serve as your moderator for today's webinar. We would like to welcome Dr. Christine Stubbe. Christine Stubbe received her doctorate of naturopathic medicine from Bastyr University in Kenmore, Washington. She completed a 3-year family practice oncology residency at Yellowstone Naturopathic Clinic and Frontier Cancer Center in Billings, Montana. Dr. Stubbe joined the medical education team at Genova Diagnostics to help provide educational support to practitioners. One of the most common questions asked during the webinar is about the availability of the presentation and the slide deck. These materials will be available on our website within a week of the webinar. If you are interested in having these resources, please click the Clinicians tab on the homepage, where you will find access to our webinars under Medical Education. Or you can also log into your MyGDX account to find these webinars. And if you don't have a MyGDX account, please click on the Getting Started link on our homepage and follow the instructions to set up an account. Now I'm going to turn over the role of presenter to Dr. Christine Stubbe.
All right, great. Thank you, Lenore, for the introduction. I am glad to be speaking today on one of my favorite topics, SIBO, or small intestine bacterial overgrowth. I am going to be talking both about the condition SIBO as well as the name of our test, the SIBO breath test. So some objectives for today. We're going to do an overview of the condition SIBO. We're going to learn what patient population you would think about to consider testing for SIBO. We're going to review the test in detail, discuss some treatment recommendations. We have 2 case examples that we're going to go over, and then we have some GI and other test considerations that we're going to look at. So what is small intestinal bacterial overgrowth? There's a couple definitions here that came from these different papers. So it's a syndrome that's characterized by an increased number or abnormal type of bacteria in the small intestine. These bacteria are both aerobic and anaerobic microbes that would normally be found in the large intestine. And currently, the technical definition would be a bacterial concentration of greater than 10 to the 3 colony-forming units per milliliter. That's generally considered significant. Now, there isn't a complete agreement out there. Some sources will say 10 to the 5, but this 10 to the 3 comes from the consensus paper on breath testing that we'll talk about in a little bit. So this is a picture of bacterial concentrations throughout the GI tract. Over on the right here, you can see the microbial load, so the colony-forming units per milliliter. And you can see that at the top of the digestive tract here in the stomach, it's a very small amount of bacteria that would be expected to be found there. And as you transit throughout the digestive tract, especially into this large intestine, into the colon here, the bacterial concentration increases significantly. So ways that the body innately prevents the overgrowth of SIBO would be, from a chemical standpoint, having enough gastric or stomach acid, pancreatic and biliary secretions. And then from a mechanical standpoint, peristalsis is very important, as well as the migrating motor complex. Basically, anything that is not moving, if there's stasis, that's going to promote bacterial growth. And then also we have our ileocecal valve that separates the small from the large intestine, and that prevents the reflux of colonic bacteria back up into the small intestine. So the compromise of any of these processes can lead to the development of SIBO. So when would you consider SIBO? What kinds of signs and symptoms are you looking for? One of the hallmark symptoms of SIBO is abdominal bloating. A lot of people will come in and say, after I eat a certain thing, I look like I'm pregnant. Other symptoms might include excessive gas or belching, abdominal cramping, diarrhea or constipation, some more upper GI type symptoms, nausea, heartburn. Also, steatorrhea is a sign of maldigestion or malabsorption of fats. Nutrient deficiencies, so some of the B vitamins, iron, macronutrients, we talked about fats, also protein can be involved there, fat-soluble vitamins, things like that. Some conditions that have a high prevalence of bacterial overgrowth, so there's a lot, there's many conditions. We think about the GI tract, so IBS and gastroparesis and other motility disorders. And then outside the GI tract, it can be prevalent in things like restless leg syndrome, hypothyroidism, diabetes, obesity. All these conditions are associated with a high prevalence of overgrowth. So some common conditions, IBS, for example, one paper stated that 78% of patients with IBS actually were positive for SIBO, and that 48% of patients that were successfully treated for SIBO no longer met the Rome criteria for the diagnosis of irritable bowel syndrome. Fibromyalgia and chronic fatigue syndrome, that's another population where SIBO is common. This one paper quoted that 42 out of 42 patients with fibromyalgia had an abnormal lactulose breath test with significantly greater hydrogen production, and that there was a correlation between the degree of pain that the patient was experiencing and the peak hydrogen level. So, you know, these numbers are going to vary from study to study, but they're still pretty significant. 77% of chronic fatigue syndrome patients were found to have SIBO in another paper. Hypothyroid's an interesting one. So in one paper, 54% of patients with hypothyroidism have SIBO compared with 5% of controls that didn't have hypothyroidism. So both hypo and hyperthyroidism, which often can be autoimmune etiology, are respectively associated with SIBO and changes in microbiota composition. So some risk factors for the development of SIBO, we talked a little bit about how stasis isn't good. We want there to be proper motility. So anything that would cause stasis to happen, sometimes you know, structural or anatomic anomalies or things that happened as a result of surgery, adhesions, strictures, anything like that can promote stasis. Motility disorders like gastroparesis or even medications that would impact a person's motility, that would slow things down. So people taking opioid analgesics for pain. Other risk factors would include irritable bowel syndrome, hypothyroidism, we've talked about a couple of these already, diabetes, anything that would impact the gut like Crohn's or celiac disease. An immunodeficiency state, the immune system can't overcome the bacterial overload, hypochlorhydria or low stomach acid, other medications like recurrent antibiotics and gastric acid suppressors, and then GI infection can also be a risk factor. A previous GI infection can be a risk factor for the development of SIBO. SIBO on a microscopic level, so it can cause histopathologic change within the small intestine. It can cause blunting of the villi, thinning of the mucosa and the crypts, increased intraepithelial lymphocytes, microscopic inflammatory changes. So this is all happening more on a microscopic level. The top slide here is showing partial villus blunting, and then the bottom picture here is showing those intraepithelial lymphocytes that are denoted by the arrows there. So there is microscopic change that happens with SIBO as well. So let's talk about testing for SIBO. Currently, the gold standard is an aspirate of small bowel fluid followed by culture of that fluid and bacterial count. So this is an invasive procedure. Basically, it's an endoscopy, and that they have to be intubated and so that the aspirates can be collected. Another drawback could be that culture-based techniques might not allow for the growth of all organisms, so it might actually be underestimating the bacterial population. There is a potential for contamination of the instruments and inaccurate sampling because of technical issues with the procedure itself. And the other kind of a bigger point is that endoscopy can only reach so far. The tube is going to reach the upper part of the small intestine, whereas colonoscopy can only reach the lower. So you're missing a substantial middle section of the small intestine just because it can't be accessed by this method. This breath testing consensus group that I'll get to in a minute quotes, "Unlike breath testing, small bowel aspiration is invasive, time-consuming, and costly, and that breath testing is a useful, inexpensive, simple, and safe diagnostic test in the evaluation of common gastroenterology problems." So let's talk a little bit about how breath testing works. Basically, they blow into a tube to capture their baseline breath measurement before they do anything. And then what they do is they drink a substrate. So the substrate that we have here is lactulose. So they're drinking that, and then the lactulose is going to transit through the digestive tract, through the small intestine. And if bacteria are present, they are going to ferment that substrate and produce a gas. Hydrogen or methane is what we're measuring. So this hydrogen and methane gets absorbed through the intestines into the bloodstream, and then those gases are going to be carried back to the lungs through the bloodstream and exhaled or expired. And then we're measuring the breath at different timed points as it transits throughout the small intestine. As far as the substrates go, I mentioned we use lactulose. And the reason is because it can't be digested or absorbed by humans, so it would be expected to pass through the entire length of the small intestine. So the advantage here is that you're going to be able to capture any sort of distal overgrowth, which is thought to be a more common SIBO presentation. It's not as sensitive as glucose. Glucose is another substrate that people may use, and it's absorbed within the first few feet of the small intestine. Thus, it can only diagnose proximal overgrowth. So the disadvantage is you're not going to be able to see if they had a distal SIBO. Let's go over the collection pack instructions. This is really important to assure that you're going to get accurate results. And I think it's important if the clinician or at least somebody in the office can review the instructions with the patient, because they are very detailed and specific. Improper collection could lead to ambiguous results. So the key instructions start with 4 weeks prior to actually taking the test. They should not have antibiotics and a colonoscopy or barium enema. 7 days prior, no laxatives, stool softeners, stool bulking agents, or antacids. 24 hours prior, the diet is pretty limited to a few foods, no probiotics. Basically, what we're trying to do here is eliminate any foods that would be fermentable by bacteria. And then 12 hours prior, they're fasting. So they can drink water, but no food, no non-essential medications or supplements, toothpaste, gums, candies, mouthwash, all these things that can be fermented by bacteria. And then 1 hour prior and also during the testing, they're continuing to fast with only water. We don't want them smoking, sleeping, doing vigorous exercise. These things can change the concentration of the breath gases, and no toothpaste. So the collection technique also may need to be reviewed with the patient, where you're actually taking the equipment out of the box and demonstrating it with them. So what they're going to do is breathe normally. So no forceful breathing here, just a normal inhale, normal exhale. So they're breathing normally, inhaling and holding for 5 seconds, and then they're exhaling into the mouthpiece that has a bag attached to it. They're not blowing really hard into the mouthpiece. They're just doing a simple exhale. And while they're exhaling, they're then going to insert a vacutainer tube and remove it after 2 seconds. The vacutainer tube is the same kind of tube that you'd see for a blood draw. And so the vacutainer part of it is going to pull the breath gases that they're exhaling into the tube for that 2-second period. There's a needle in the device to help puncture the rubber stopper on that tube. And then what we want them to do is to record the time both on the label on the tube and right here on the requisition form. So this little chart is going to be right on the requisition form. We want them to record the exact time that they took that particular sample. There is a great demonstration video for patients to watch. It's right on the SIBO website, so our main website, www.gdx.net, and then you can click to the link that's here for the video. So let's talk about test interpretation. So in the field of SIBO and SIBO testing, standardization was lacking regarding indications for testing, test methodology, interpreting results. And so a consensus group was formed to attempt to try to begin the process of standardization within this field. So this group was formed by physician scientists. They were selected based on their active or recent research in the area of breath testing and or people who did a high volume of breath testing clinically. A total of 17 physician scientists were selected from the US, Mexico, and Canada. And there were pre-meeting survey questions that were sent to consensus group members to identify gaps in knowledge. And then they convened, and these statements were voted on and accepted if greater than 70% of the participants agreed. So a consensus was reached on 26 different statements in the areas of indications for testing, preparation, performance of testing, interpretation of results, and identifying additional gaps in knowledge. So this is a picture here of our 3-hour SIBO breath test on the left and our 2-hour test on the right. Basically, the choice of one over the other relates a lot to transit time. And so if you have a patient that has slower transit or constipation, where the lactulose might move more slowly through their system and you want to capture a broader time frame, then you might go for the 3-hour test. But the 2-hour test should be sufficient for those patients who have normal transit. So we'll look at the test components here. At the very top of the page, we can see this graph in blue, and we're plotting the change in hydrogen and methane. So this blue line with the white circles represents the hydrogen as it transits through the intestines, and then this black line with the black diamonds represents methane as it transits through the intestines. The actual numbers that get plotted into this graph at the top are shown in the middle of the page here. So we have the hydrogen at the actual parts per million measurement at each of these timed points, methane. We also look at carbon dioxide for quality control. We look at their actual collection times. This is important because we know that it's tricky sometimes to be perfect. We try to encourage that as much as possible to try to stick to the recommended times, but we like to see the actual collection times to see how closely they match up with the recommended collection times. And then at the bottom is the interpretive information, so the evaluation for hydrogen at the bottom left and the evaluation for methane at the bottom right. So let's jump in and talk about that interpretation, particularly the evaluation for hydrogen. So the definition for a positive test would be a rise of hydrogen of greater than 20 parts per million over baseline in the first 90 minutes of testing is positive for SIBO. And this evaluation for hydrogen is based on that consensus paper that I just mentioned. This cut point is also widely seen throughout the literature. The significance of an elevated baseline hydrogen before they even drink the lactulose solution, so if the baseline is high, in patients that did follow the fasting and dietary guidelines and the collection pack instructions, the significance isn't known. In a symptomatic patient, some clinical groups that have expertise in SIBO may consider an elevated hydrogen baseline a positive test. The consensus paper didn't necessarily reach a consensus on that point. Approximately 8 to 27% of individuals do not produce hydrogen because of the presence of methanogenic microbiota, which consume hydrogen molecules to produce that methane gas. So low hydrogen throughout all the timed points in a symptomatic patient may reflect a false negative result. And at that point, the clinical attention should be shifted to the evaluation for methane. So how do we evaluate methane? The consensus group and other papers refer to an absolute value of 10 or greater at any point during the test as a methane positive result. So on our test, a result that's 10 or greater is going to be outlined in red and flagged with an H. That would be a positive result. The peer-reviewed literature suggests an association with certain clinical conditions and methanogen overgrowth at levels as low as 3 parts per million. So in that case, we will flag results that are between 3 to 9 with yellow. This may indicate the need for clinical intervention, especially if the patient's symptomatic. So you always want to look at your patient, look at the symptoms, and that will guide whether you're going to decide to treat or not. Emerging literature suggests that unlike hydrogen, an elevated methane level at baseline is common. So elevated baseline hydrogen, unclear the significance, but elevated methane baseline is quite common. So using breath methane levels for SIBO assessment is controversial. There's a lack of validation related to specifics to diagnose, such as the timing that would qualify it as a SIBO or the magnitude of increase. So that line upsloping, the change over baseline, that's not fully agreed upon. The rise of methane during breath testing appears to not be as sharp as hydrogen, but clinicians and researchers are still looking at methane measurements to address other clinical conditions like constipation and irritable bowel syndrome and obesity. With constipation, methane gas itself may slow intestinal transit, and patients with methane predominant SIBO have been found to be 5 times more likely to have constipation compared to individuals with hydrogen predominant overgrowth. And the severity of constipation has been found to directly correlate with the methane level. So we also look at carbon dioxide levels, and the reason is that if the sample comes back with carbon dioxide that exceeds the acceptable limit, it could indicate that there's actually room air in the sample, not the patient's breath. And that likely happens at the time of sample collection. So it's important that they're following all the steps accordingly. If the carbon dioxide levels exceed acceptable limits, then the sample integrity is questionable and the results are designated as non-reportable. So they would get an NR or non-reportable for the breath gases, for the hydrogen and methane, and then they'd have an X here indicating that the carbon dioxide level was not acceptable. I mentioned we look at the actual collection times. So these get transferred from the patient's requisition form on the right here onto the test report itself. And so you'll see the actual collection times and the actual intervals showing up here. And so the actual interval, if it's not followed correctly, the interpretation should be made within the context of the altered collection schedule. And in general, deviations of a few minutes is not going to significantly alter the interpretation. However, if the 90-minute interval is missed, we know that the evaluation for hydrogen is based off of anything leading up to 90 minutes. That needs to be taken into consideration. So, you know, for example, if they were driving in their car or something and couldn't take it at the 90-minute mark and arrived at their destination and actually took it at the 110-minute mark, you know, is that still SIBO or not? The accepted transit time, or the average transit time for most normal individuals, is about 90 minutes. So beyond 90, the question is, has the lactulose actually made it into the large intestine at that point? So that's something that needs to be considered with the patients who don't follow the schedule exactly. So as far as treatment of SIBO, so the majority of patients that are diagnosed will relapse. So one study found that 44% of patients treated successfully with antibiotics will relapse within 9 months. This is common. I speak with a lot of clinicians about this test, and it's something that I commonly hear on the phone, and even the SIBO experts out there talking about it talk about this relapse. And so beyond just treating the overgrowth as a goal of treatment, you also want to look at the underlying cause. So we'll talk about that in a little bit. And then providing nutritional support is important as well. So as far as treating the overgrowth, rifaximin is used. It's a prescriptive antibiotic. Rifaximin plus neomycin or rifaximin plus metronidazole. A lot of people might use that combination for the methanogens. Botanicals that are used include berberine, allicin, which is a component of garlic, oregano oil, neem. There's lots of other things that can be considered for botanical treatment. And there are papers that are published saying botanical treatment can be as effective as rifaximin for that hydrogen producing SIBO. And so, you know, one is not necessarily better than the other, and everybody is going to be different as far as what they respond to. You also want to consider providing nutritional support. So if their SIBO has gotten bad enough to the point where it's actually producing nutrient deficiencies or insufficiencies, you want to think about repletion. So, you know, all those nutrients we talked about in the beginning that can be associated, the fat-soluble vitamins, the Bs, iron, you want to think about replacing these things if they truly are deficient. Some common diets prescribed for SIBO include the specific carbohydrate diet, which is exactly what it sounds like. There's certain carbohydrates that are allowed and certain that are eliminated to not be, the bacteria don't have substrate to ferment to produce those symptoms in the patient. Same concept with the low FODMAPs diet. FODMAPs are basically fermentable carbohydrates. The actual acronym FODMAP stands for fermentable oligomonosaccharides and polyols. So these are basically just carbohydrates and sugars that the bacteria ferment to produce those gases, which produce symptoms in the patient. And then an elemental diet is another diet that may be prescribed for patients. It's kind of getting back to the basic building blocks of the macronutrients. So carbs, carbs, fats, and protein. So the basic building blocks of those, it would be essentially a pre-digested supplement that the patient is ingesting. So it kind of takes the burden off the GI tract from having to work on the digestion if its digestive capacity is limited. So I think addressing the cause is a big point here. I mentioned the migrating motor complex as being important for motility. So the migrating motor complex is the waves of electromechanical activity that sweep through the intestines in a regular cycle, and it sweeps bacteria from the small intestine to the large intestine and inhibits the migration of that colonic bacteria up into the small intestine. So to support the function of the migrating motor complex, which does its work in the fasted state, you might consider meal spacing every 4 to 5 hours with an overnight 12-hour fast. Some people will prescribe things like prokinetic agents. There's pharmaceutical agents like low-dose erythromycin, low-dose naltrexone. Some natural agents that people might use include ginger, herbal bitters. There's a botanical product called Iberogast. So there's a lot of things you can do to get the motility working. And then as part of addressing the cause, you might consider revisiting that earlier slide on risk factors and associated conditions and addressing those things. A few examples of addressing the cause might include discontinuation of medications. Now, this is something that you weigh with each patient, and it's a discussion between the clinician and the patient whether that's an appropriate step to take or not. So, discontinuing acid blocking medications, usually people are doing a taper with that, or medications that slow transit like opioid analgesics. How else would you address their pain if you took them off of this medication? Treating hypothyroidism. So there was one paper that showed an association with treatment of hypothyroidism with levothyroxine and a greater incidence of SIBO. So that doesn't necessarily indicate causation. It's just an association that was found in this one paper. Another question I have would be what's actually causing the hypothyroidism. So, we're trying to get to the root cause of the SIBO, but then we're trying to get to the root cause of the other conditions that could be setting them up for SIBO as well. So there's some digging and investigative work that has to be done here. Hypochlorhydria or low stomach acid. So you might consider giving bitters, betaine hydrochloride, things like that to help. But then the underlying question is what's causing the hypochlorhydria and what can you do to improve that? Some causes can't be reversed. So surgical alterations, aging was another risk factor. We can't reverse aging necessarily. So ongoing management may be necessary. Something that's helpful for surgical alterations might be something manual like visceral manipulation to break up some of those adhesions. I have a website at the bottom of the page here. It's www.siboinfo.com. It's a website maintained by Dr. Allison Seebecker, and it includes a lot of treatment considerations. So if you want to dive in more and learn more about treatment, she has a wealth of information on that website. We get questions about when to retest. So in a patient treated for SIBO, many variables are going to affect the decision of when to retest. So, and it's going to be different from patient to patient, depending on their underlying condition and the severity of the condition, the length of treatment, what treatment was used. The North American Consensus Group paper that I keep referring to recommends that antibiotics should be avoided for 4 weeks prior to testing, but this recommendation usually applies to initial testing for SIBO. There are emerging clinical recommendations that suggest retesting in patients within a few days of completing their antimicrobial regimen because they want to see if that actual regimen was efficacious or not. And the North American Consensus Group paper does mention that breath tests can be performed shortly after cessation of antibiotic therapy to confirm eradication. So let's go through a couple cases here. This first case is a 34-year-old female. She presented with bloating and alternating diarrhea and constipation. And these symptoms have been ongoing since she caught a GI bug while traveling in Central America 9 months ago. She had never experienced these types of symptoms prior to that. She does find certain foods problematic, and she eats more of a paleo diet to try to control symptoms. A paleo diet's more of a low-carb diet. And the patient is very active, keeps busy with work and travel, but the IBS symptoms have interfered with daily living. And these are her results. And so we see that she's positive for hydrogen and then has a moderate finding here for the evaluation for methane. And so the first thing that I do is I look at the actual collection times. We want to make sure she followed the schedule. And so the actual collection times, and perhaps it's a little bit smaller on your screen here, the picture of the test report, but the actual collection times are in the middle of the page here. And so we're looking at the intervals here and seeing that they line up with the intervals at the top of this chart. So 0, 20, 40, 60, 90 minutes, 120, 150, 180. So she appears to have followed it perfectly, which is what we like to see. And then the evaluation for hydrogen, so the change in hydrogen was 58. So remember, the definition is the increase over baseline by 90 minutes. So if we look at the hydrogen line here in the chart, we see all these numbers. And what we're looking for is the highest number in the first 90 minutes of the test. And so the highest number along this line here actually occurred at sample 4, which was the 60-minute sample. Her number is 63. And what we do is we subtract the baseline, which here was 5. So 63 minus 5 is 58, and that's how we came up with our number, the change in hydrogen. So 58 is much higher than the expected value of 20 parts per million or less. And so she has SIBO. The evaluation for methane shows up in this yellow box, and so the peak methane level at any point during the test. So if we go back to our chart here and look at methane, the second line here in the chart, we're looking for the highest number, and so we see 7 at 60 minutes, we see 7 again at 120 minutes, so 7 seems to be the highest number, and that's how we get our evaluation for methane. So the expected value is 10 or greater as a methane positive test, but remember we talked about how there may be clinical significance of a number that's 3 to 7. And so as far as treatment goes, since the patient did have a mixed IBS type picture, she had both the diarrhea and the constipation, the clinician chose to treat both methane and hydrogen producing organisms. And so the regimen that the clinician chose in this case was a botanical regimen. So there's a few products here, Candibactin AR and BR. They chose Alamed for the methane, and they put that patient on that regimen for 6 weeks. They also instructed them to begin a low FODMAPs diet, which didn't turn out to be much different from the paleo type diet that she was already doing. And then the clinician advised meal spacing every 4 to 5 hours. So at a follow-up visit, after 2 months, the patient had improved. So there wasn't any follow-up testing. The patient did continue with meal spacing and a modified FODMAPs diet. So the goal is not continuous FODMAPs or continuous carbohydrate restriction. Fermentable carbohydrates are important to the health of the commensal bacteria of the large intestine. And so the goal would be to introduce those fermentable carbohydrates or those resistant starches over time. They might not be able to do well with it all at once right away, but over time it's important because you want the bacteria in our large intestine to be healthy, and this is what they need to be healthy. We have another case here with a 66-year-old male who has bloating and excessive belching and flatulence. He's had severe constipation for as long as he can remember, has up to 2 bowel movements per week that are difficult to pass, but he considers this pattern normal for him. So that's always an important thing to think about with patients is they may say, I'm normal and healthy, but this is the way they've always been, so they don't know any different. And so, we know that 2 bowel movements a week is not healthy. People should be much more regular than that. This patient also is obese, has hypertension, hypothyroid, diabetes. He takes oxycodone daily for a back injury that he had 3 years ago, and he eats a standard American diet. And these are his test results. So we see that this is a methane positive test. So 57 was the highest methane point at any point during the test. So if we come down into the chart here and we see the methane, the second line here, we see that there's an elevated baseline. He's at 44. Remember, the expected value over here is 10, and his baseline starts off quite elevated, and it kind of remains the same throughout the test. And so in the chart up here, remember the methane is the black line with the black diamond. So we're not seeing a significant upslope of methane. We're just kind of seeing it stay pretty stable throughout the test, with the high point being 57, and that occurs at the 60-minute mark. And so this is positive for methane. The hydrogen was normal. I always like to see if the collection schedule was followed correctly. And so again, with this patient, it looks like 0, 20, 40, 60, 90, 120, 150, 180. He followed it perfectly into the T. That's what we like to see. And so the clinician treating this patient chose to treat the methane-producing organisms with rifaximin plus neomycin for 14 days. They also wanted to address the motility issue. So they prescribed a prokinetic, a natural product, Modal Pro, which is a combination of ginger, 5-HTP, and some other things, indefinitely until the chronic constipation resolves. Along the same lines, they prescribed magnesium daily to help with regularity. They switched the levothyroxine prescription to Armour Thyroid. They recommended increasing water intake from 1 cup daily to at least 1 to 2 liters daily. Hydration is really important for regularity as well. And while fiber is important for constipation, it was avoided initially while they're addressing the SIBO. Sometimes giving a patient fiber who has SIBO is just going to upset the problem because the bacteria, the SIBO, can potentially ferment that fiber and create more of an issue. And then also the clinician was thinking more globally how to help this patient and recommended a low carbohydrate diet, which we know can help with SIBO, but also it can be good for diabetes and for obesity. And the long-term focus with this patient is really going to work on his overall health conditions and habits that may predispose to SIBO. So addressing his diabetes, his hypothyroidism, his standard American diet, and his oxycodone use. The recurrence of SIBO is common, especially if the underlying conditions are not addressed. And this patient's lifestyle and health conditions are inflammation promoting, So transitioning to an anti-inflammatory diet and lifestyle may take time if they were thinking about pulling him off that oxycodone prescription. So it may not be an overnight experience. This patient also had a GI effects comprehensive stool analysis ordered, and the results were pending. If there are other GI abnormalities, for example, pancreatic insufficiency, then pancreatic enzymes can be given to help with digestion. We do know that pancreatic insufficiency is common with diabetes. So we have an additional scenario here. Some clinicians will ask us about a flatline test and the significance. So flatline would just be you see low hydrogen and low methane throughout the entire test. So this could just indicate it's a negative test for SIBO and that you might consider other testing to assess the etiology of the patient's symptoms. If both hydrogen and methane are low all 3 hours, it could also suggest the presence of hydrogen sulfide producing bacteria. So to make hydrogen sulfide, those bacteria need to consume hydrogen that otherwise would have gone to the bacteria that are making methane. And so you wouldn't necessarily see hydrogen or methane showing up on the test report because it's all going into the production of hydrogen sulfide. There isn't a test for it at this time to test hydrogen sulfide gas. One thing the patient might report is that their gas smells like rotten eggs. So if this is what they experience, then they might actually have, and they had the low hydrogen and methane throughout the test, then they might have hydrogen sulfide bacteria. Another reason for a flatline test would be that the patient may not have followed the collection pack instructions correctly. So, perhaps the breath didn't make it into the tube. If it doesn't make it into the tube, then it's going to be flatlined or low appearing throughout the test. It may be low if they just completed antibiotics. So remember, the instructions say to wait 4 weeks after discontinuing antibiotics. And so that's kind of the point of the antibiotic, is to decrease the bacteria that make the breath gases. So again, back to that conversation about some clinicians may advise their patient to collect immediately after finishing the antibiotics to ensure efficacy of treatment. So if you see the flatline result, then it would suggest that the treatment worked. So GI test considerations, just to review when you would order SIBO testing, anything related to the GI tract, IBS, GI symptoms, bloating, again, is kind of a hallmark. Those patients who don't do well with carbohydrates or FODMAP foods, they say, after I eat this particular carbohydrate, I just feel awful. Symptoms that happen soon after eating, that's more upper GI or small intestine. You'd expect it to happen pretty soon after eating. Any patients who have unexplained abdominal symptoms, or, you've done workups and you just can't figure out what's going on with the patient. Maybe it is SIBO. And then again, revisiting that slide on the predisposing conditions as far as who you might consider ordering SIBO testing for. And then, of course, it's important to designate someone in the office to go over collection pack instructions with each patient so you can get the most optimal results. Some other GI test considerations for those similar symptoms that I just went through, you might consider the GI effects. It's a comprehensive stool test, and it can identify pancreatic insufficiency, and it's looking at biomarkers in the area of digestion, as well as absorption. It's looking at biomarkers of inflammation. It's evaluating dysbiosis, yeast overgrowth, and parasitic infection. You can also think about the food antibody panel. So if a patient or you are really curious about knowing if there's an immunological reaction, maybe they just notice that certain foods bother them and they want to see if there's some sort of immunological reaction. You can do IgG testing for these certain foods. Also, the IgG reactions can extend beyond the GI tract. You know, they might have IBS type symptoms with certain foods, but they also might have skin issues or joint issues, so that are delayed. You know, it can happen within a few days of eating a food. So the IgG food antibody test could be used for those types of patients. And then, of course, the celiac and gluten sensitivity panel in patients, you want to rule that out. So we get asked if the GI effects stool profile can diagnose small intestine bacterial overgrowth. And it can't diagnose it, but there are some markers on there that may be suggestive of SIBO. So those would include elevations of products of protein breakdown, fecal fats, and then unexpected or extreme elevations of the total short chain fatty acids and butyrate. And then we have another test, a nutritional test called the Nutrival, that can assess a person's need for specific nutrients. And so as it relates to SIBO, again, some of those nutrients that might become deficient would include the B vitamins, some of the macronutrients, fat-soluble vitamins. So the Nutrival will tell a person's need for specific nutrients. Also on the Nutrival, we look at urine organic acids, and what's circled here are the malabsorption and dysbiosis markers. And so what we're looking for is a trend. There's 10 markers here. If you see most of them shifting to the right, like in this case, hardly any of them are falling in that green optimal zone, then it's going to be suggestive of a dysbiosis. Something's going on in the GI tract, and you might want to take a closer look. Usually we'll recommend stool testing to get a better picture of what that actual imbalance is. So I want to thank you all for being with me today, and perhaps there's some questions that came in, Lenore, and I'm happy to answer them.
Absolutely. Thank you so much, Dr. Stubbe. Again, that was a tremendous presentation, and we did receive quite a few clinical questions. A lot of them surrounded the topic of collection package instructions, and so I do want to remind the participants that we do have a great demonstration video for patients to watch and clinicians to watch found on the SIBO page on the www.gdx.net website. But let's start with this question here. Why is it so important to follow the collection package instructions?
So if it's not followed at any of those points, the preparatory instructions and then the actual collection itself, it could result in an inaccurate breath gas level. So, for example, let's say they didn't follow the diet. So for 24 hours prior to taking the test, they're supposed to restrict foods that would be fermentable. So they're really limited to things like fermentable carbohydrate things. So they're limited to things like plain chicken or turkey or fish or something like that. If they ate a huge salad with lots of beets and starchy types of vegetables, potatoes and stuff, if they ate that within the 24-hour period, then they run the risk of it being in the large intestine, so that, let's say they ate it for dinner the night before and then they wake up in the morning and want to collect their breath. Well, dinner from the night before with all the fermentable starches and everything could be sitting in their large intestine, and all those bacteria are going to town, creating lots and lots of gas. And so that could be normal for the large intestine, but we're not assessing the large intestine, we're assessing the small intestine. So we don't want that background gas formation coming from the large intestine to be a factor in this test. So the hope is that they're not eating that kind of stuff. They're not feeding the bacteria of the large intestine. All of that is getting cleared out. And then they do a 12-hour fast right before they start their breath collection with just water. So this is ensuring that all that kind of background gas is out of the way. So when they take that first drink of that lactulose solution, that's what's getting fermented, and that's the gas that we're picking up in the small intestine if they do actually have SIBO.
Thank you. Regarding 7 days prior to sample collection, on one of the slides earlier that you discussed, it does mention laxatives to discontinue that 7 days prior to sample collection. Would that include natural laxatives like magnesium and vitamin C?
It would if it significantly alters their transit time. And so if it actually is normalizing their transit time, then that could be okay. But if they take a laxative and they have really loose stools and they're going several times a day, then that's speeding up their transit. And we don't want to do that because the results of the test are based on a more normalized transit time. And so if those natural laxatives are actually normalizing their transit time, then it could be okay. But then, they're not supposed to take any non-necessary supplements for the day before the test either. And so the hope would be that they wouldn't be taking the vitamin C or the magnesium for that day before. But I realize 7 days is kind of a long time, but that is just to ensure that they have a more normalized transit time at the time of the test.
Thank you. Also with the collection package instructions, it mentions 4 weeks prior to the test to discontinue antibiotics. Does this also include herbal antibiotics?
Yes, it would.
Okay, so regarding the challenge drink lactulose, can that possibly make patients feel worse?
It can. It doesn't make everybody feel worse, but if you think about it, if they had SIBO and they drink something that's going to produce a positive test by producing those gases, that could kind of replicate the symptoms that they're used to experiencing. So it's possible it could make them feel worse. I don't know that there's a way around that, other than preparing the patient that they might not feel that great at the time of testing. But if you really want to get those results, then you kind of have to go through the test. Now, if the person has a lactulose allergy, an actual true allergy, then they wouldn't be a good candidate for the test. They probably would feel much, much worse. Also, people who have lactose intolerance, even though the substrate is lactulose, not exactly the same as lactose, sometimes they can experience the symptoms that they might experience had they consumed lactose. That's not necessarily a life-threatening thing, but it certainly can make them feel uncomfortable. And so you have to kind of weigh the pros and cons here of doing the test and getting the results and the patient feeling uncomfortable. But it's kind of hard sometimes to predict which patients are going to do okay with it and which are going to feel horrible.
Thank you so much. So in the interest of time, we will end our question and answer period there. For additional education materials, we'd like to encourage you to visit our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and just more information for each of our profiles after taking advantage of the materials found on our website. Please feel free to contact client services with any additional questions. You'll see a contact number on the slide for both US and UK customers. Additionally, please call client services if you need assistance in setting up a MyGDX account. We will also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results. Finally, we'd like to encourage you to register for our upcoming webinars on www.gdx.net. Next month, we will have Dr. Michelle Maddox presenting GI case reviews. Thank you again, Dr. Stubbe, for a wonderful presentation.
Thank you so much. Have a good day.